Hi, my name is Dr. Kirsten Cook, and I'm an internist at the University of Florida College of Veterinary Medicine, where I practice both internal medicine and oncology. And today I'm going to review oncology, both chemotherapy drugs as well as various cancers, for your board review. We treat patients with cancer because animals, cats and dogs, now have a longer lifespan than they have had in the past. This is due both to preventative care as well as client awareness. And what we know is that animals that are older than 10 years of age, 50% of them die from cancer. These animals are also family members, and people have started to see information on the internet. They know family members or friends who have had cancer, and they know how they've been treated, and they've started to demand the same sort of treatment for their pets. What I'm going to do today is to review first the cell cycle very briefly. I'll talk about some of the principles of chemotherapy, and then about drug classification, and then I'll move on into some of the specific diseases and what we do to diagnose them and sometimes how we treat them. When we talk about the drugs, what I'll review are the various classes of drugs, their mechanism of action, specific toxicities, especially ones that are associated only with certain drugs, some species differences, and then the most common clinical uses for those drugs. So this would be the cell cycle. And here you can see the cell cycle is divided up into essentially two phases, the mitotic phase and the resting phase. The resting phase is further broken down into 4 phases. The G1 phase, which takes several hours to several days, is associated with the synthesis of RNA and enzymes that are needed for DNA production. The next part of the phase is the S phase, which stands for the synthesis phase, and it is during this period of time that DNA is synthesized. The G2 phase takes about 2 hours, and it is during this time that you have synthesis of the mitotic spindle. The fourth part of the resting phase is the G0 phase, or the resting phase, where the cell is not proliferating. And then finally we have the mitotic phase. When we speak of cancer drugs, we break them down into 2 major types. Cell cycle specific drugs, which affect one phase of the cell cycle, such as vincristine, which affects the M or the mitotic phase. Cell cycle non-specific drugs tend to affect more than one phase of the cell cycle. For example, cyclophosphamide affects both the G1 and the G2 phases. These chemotherapy drugs disrupt cell growth and division, and they tend to affect rapidly dividing tissues. This means they tend to affect the neoplastic or cancerous cells, but also means that they affect bone marrow and the gastrointestinal tract, and it is there that we see most of our side effects. One thing to keep in mind is that these drugs kill a constant percentage of cells rather than an absolute number. And what this means is if you start off with a cell that has 100 million cells, and you have a drug that kills 99% of them, that still leaves you with 1 million cells after that drug has taken effect. And that's one of the reasons that it's very difficult to cure cancer with chemotherapy. A couple of things to think about when we talk about chemotherapy. Within limitations, more drug is better. The higher concentration of drug we can achieve, usually the greater kill we can achieve. There are some limitations to this, however, because these drugs also have significant toxicities, and so we have to balance that out. Also remember that because they kill a constant percentage of cells rather than a certain number, is that you can't kill all of the cells with your chemotherapy. You may kill most of them, but if you just leave one cell behind, that cell can then go on and divide and produce additional tumors. More tumor or larger tumors is definitely not better. You would rather address a tumor by treating it either with chemotherapy or with other treatment modalities such as surgery when it's smaller. And this is because, again, you're killing a certain percentage of cells, and also because when you have a larger tumor, many of those cells won't be dividing, which means some of the cells will not be susceptible to chemotherapy. And chemotherapy should not be used as a last resort. When we use chemotherapy as a last resort, typically what we find is that we get a negative outcome. The animals don't respond. Oftentimes they're already very ill, and then we give them a drug that makes them feel sick. And so we definitely try to treat animals sooner rather than later. There are a number of different indications for chemotherapy. The most common is if we have systemic neoplasia, such as lymphoma. We also use it to treat tumors that have a high metastatic potential, including osteosarcoma and hemangiosarcoma. Occasionally, chemotherapy is used for local tumor control, such as the use of intralesional therapy with, for example, squamous cell carcinomas in horses, where we will give intralesional cisplatin or carboplatin. But something to keep in mind when we're talking about tumors is that with the exception of lymphoma, chemotherapy is generally ineffective at treating gross disease. So if you have a large tumor, for example, a large sarcoma on a back or on a leg, or a mast cell tumor, these are not likely to respond to chemotherapy alone. So that's when you have to consider adjunctive therapy. Most of the time when we do chemotherapy, we treat with what we call combination protocols. So we use more than one drug, and we do it in various cycles. Each drug, when we put a chemotherapy protocol together, a combination protocol together, there are a number of principles that we use when we design those protocols. One is that each drug obviously must affect part of the cell cycle, because that is how the chemotherapy drugs work. Each drug should also have a different mode of action, because we don't necessarily want to treat them with drugs that act in the same way, similarly to not using antibiotics that affect the same types of bacteria. We also want them to not have overlapping toxicities. That often allows us to use higher drug concentrations, higher total drug concentrations, because we can use two different drugs that don't have the same toxicities and achieve a higher cell kill. And then again, obviously, we don't want the drugs to interfere with each other's actions. Similarly to using antibiotics that are either bacteriostatic or bactericidal, we generally recommend not using a bacteriostatic drug and a bactericidal drug. And the same thing follows with chemotherapy drugs. You don't want one drug to interfere with the other. As we mentioned before, the chemotherapy drugs tend to affect cells that are rapidly dividing. And this most commonly means that we see side effects affecting the bone marrow. We see myelosuppression, decreases in numbers of the white blood cells, the platelets, and occasionally red blood cells. Now, the decreases that we see correspond to the lifespan of those different cells. White blood cells, more specifically the neutrophils, have a much shorter lifespan than platelets. They're usually in circulation for hours. This means that neutropenia is probably the most common sign that we see associated with chemotherapy. We can, with some drugs, and sometimes after prolonged chemotherapy, see decreases in platelet numbers, but they have a longer lifespan, usually circulating for days, before they're removed. And so we don't tend to see thrombocytopenias as commonly as we see neutropenias. Red blood cells have a long lifespan. Their average lifespan is between 90 and 100 days. And so it's actually very uncommon that we see anemia that is strictly due to the chemotherapy. We may see anemia due to anemia of chronic disease or due to gastrointestinal hemorrhage because of some of the drugs that they receive, but generally anemia is uncommon as a side effect for our patients. But bone marrow suppression is the most common side effect associated with chemotherapy. We also see gastrointestinal signs because the lining of the intestine turns over every 3 to 4 days. And this means that we can see signs such as vomiting, diarrhea, or loss of appetite relatively commonly with chemotherapy. But the degree of side effects that we see is something that we often have control over, and so we can influence how sick these animals get, and we can alter our drug protocols to try to prevent a lot of these signs. Moving on to the drug classifications, we break most of our chemotherapy drugs down into 6 groups: the alkylating agents, antimetabolites, antibiotics, plant alkaloids, hormones, and then miscellaneous drugs. The alkylating agents are cell cycle nonspecific drugs, and they cross-link DNA. What this means is that the cell then can no longer undergo replication, and so the cell dies when it tries to divide. Examples of alkylating agents include cyclophosphamide, chlorambucil, and melphalan. With this particular class of drugs, we often see what we call class cross-resistance. That is, when a tumor or a tumor type becomes resistant to one alkylating agent, it is often resistant to other alkylating agents, which means if the animal comes out of remission, other alkylating agents may not be effective. Cyclophosphamide is activated by the liver and then excreted by the kidneys. This is important because you need to consider reducing the dose, usually by 25% or more, in animals that have significant renal failure. The most common toxicities associated with cyclophosphamide, just like with many of the other cancer drugs, are bone marrow suppression and gastrointestinal signs. Somewhat unique to cyclophosphamide is the toxicity that causes sterile hemorrhagic cystitis. This is due to one of the metabolites of cyclophosphamide called acrolein that leads to a significantly hemorrhagic cystitis. The animals will often urinate what looks like large volumes of blood, but if the urine is evaluated and cultured, it is sterile. If this is seen, the animal cannot receive cyclophosphamide again, and so what we will do is we will substitute some other agent for cyclophosphamide in that treatment protocol. It has been reported that some animals have developed transitional cell carcinomas with prolonged use of cyclophosphamide, and so some clinicians will recommend not using cyclophosphamide for more than 9 cycles. That seems to be somewhat anecdotal. We don't seem to have too much of a problem with it, although, as I mentioned before, if we do see hemorrhagic cystitis in a patient on cyclophosphamide, we do no longer use that drug. Cyclophosphamide is also known as Cytoxan and is used commonly in lymphoma protocols. It's also used as a combination treatment for hemangiosarcoma as well as some other soft tissue sarcomas. Chlorambucil is another alkylating agent that is also excreted through the kidneys. The most common use for chlorambucil is one as a substitute for Cytoxan in those patients that do develop sterile hemorrhagic cystitis, and in some protocols, chlorambucil will be substituted for Cytoxan if the animal is in complete remission. It's also used pretty commonly for the treatment of chronic lymphocytic leukemia, most commonly seen in dogs. It can cause bone marrow suppression, although that is relatively uncommon, and when it occurs, it's also relatively mild. And it can also cause some gastrointestinal signs, some vomiting and diarrhea. But again, as far as chemotherapy drugs go, it is a relatively mild drug as far as the likelihood of side effects. It's also called leukeran. Melphalan is the last alkylating agent that we'll talk about. Its trade name is Alkeran. It does cause pretty significant bone marrow suppression, and this is one of the drugs that can actually specifically cause thrombocytopenia. So it's important when you're using this drug that in addition to looking at neutrophil levels, that you look at platelet levels as well. And if the platelets or the neutrophils decrease significantly or to a dangerous level, then typically you need to reduce your dose. Typically we'll reduce it by 25 to 30% to start out and see whether that works. And if it does, we may start to slowly increase the drug dose again. It does cause gastrointestinal side effects, but the bone marrow effects are probably the ones we worry about the most. Melphalan is most commonly used for the treatment of multiple myeloma, but it is also a part of some of the rescue protocols for lymphoma for patients that have come out of remission on some of the standard protocols, such as the COPS protocol or the Wisconsin protocol. Moving on to the antimetabolites, these are cell cycle phase specific. These affect the S phase, or the synthesis phase. And the reason is that these tend to be purine or pyrimidine analogs, which are necessary for formation of DNA. So these analogs are inserted into the DNA, which renders it non-functional. Antimetabolite drugs that we'll go over today are methotrexate, cytosine arabinoside, and 5-fluorouracil. We'll talk a little bit about 5-fluorouracil, although it's not that commonly used. It is a pyrimidine analog. It also does inhibit nuclear processing of ribosomal and messenger RNA, and it's unknown at this time which of these two mechanisms of action is the most significant. It's metabolized by the liver. The primary reason that I'm discussing it today is that it is absolutely contraindicated in cats. Cats that are treated with 5-fluorouracil develop seizures and they die, and so we do not use it in feline patients. The other thing to keep in mind is that it can be fatal if it is ingested. In dogs, it's not a drug that we use that commonly. It's actually used more commonly in people to topically treat things like squamous cell carcinomas on the skin. And if a dog ingests a small amount by licking it, that's probably not going to be a big problem. But if they get a hold of the tube of the 5-fluorouracil, which is also known as Efudex, it actually can be fatal. They can have some of the same neurologic signs that cats can, and they can die from it as well. So it is used in dogs. It's not used in cats, and it's not used that commonly in dogs, partly, again, because of its toxicity. Cytosine arabinoside is also a pyrimidine analog. It is very rapidly metabolized by the liver and very efficiently removed from circulation by the kidneys. And for this reason, to maintain or achieve adequate blood levels, it's typically given by continuous infusion. And you will see various infusion protocols ranging anywhere from a period of 4 hours to a period of 48 hours. So there's quite a variety of recommendations. Now that's not always feasible, and so one of the things that we have turned to is giving the cytosine arabinoside by multiple subcutaneous injections. Usually we divide the total dose into 4 doses and give it subcutaneously twice a day for 2 days. One of the unique things about this drug is that it does cross the blood-brain barrier, and because of this, it is commonly used for central nervous system tumors. Also, because it is so efficiently removed from circulation by the kidneys, it is a common part of protocols that are used to treat renal lymphoma, as well as for lymphoma rescue protocols. Methotrexate, although it is not a purine or pyrimidine analog, it is a dihydrofolate reductase antagonist. And so by inhibiting this enzyme, dihydrofolate reductase, it prevents the production of a product that is required for purine precursors. And so it actually eliminates some of these purine precursors that are necessary, again, for DNA synthesis. It's metabolized by the liver and excreted through the kidneys by tubular secretion. Some people will recommend, if you have an animal that has chronic renal failure, that you also reduce the dose in these cases because of the renal excretion. This is another drug that crosses the blood-brain barrier, and so it is also used to treat brain tumors as well as to treat lymphoma. We very commonly see GI side effects associated with this, and so oftentimes we will automatically treat these animals with antiemetic or anti-nausea medications such as metoclopramide. We do sometimes also see myelosuppression, although it doesn't seem to be as severe as some of the other drugs. Most of these side effects, at least associated with the methotrexate, are dose-related. And so if you use a very high dose, you're much more likely to see these side effects. These side effects can be reduced with leucovorin, which is a reduced folate, and so essentially it eliminates the need for the dihydrofolate reductase. Moving into the antibiotic category, these are also cell cycle phase nonspecific. The most commonly used antibiotic chemotherapeutic agents include doxorubicin, actinomycin, and mitoxantrone. These fall into the class anthracyclines, and they're derived from cultures of streptomyces. These act by two mechanisms. One is that they induce the production of oxygen-free radicals, leading to free radical damage. They also inhibit topoisomerase II, which is responsible for the coiling and uncoiling of DNA during replication. And so what happens is when these drugs are given, by inhibiting the topoisomerase II, it actually prevents the DNA from recoiling once it's replicated, and so the cell dies. Doxorubicin is probably the most commonly used antibiotic chemotherapeutic agent. It's metabolized by the liver, and so it is recommended that in animals that have either biliary cancer or evidence of liver disease, that have a bilirubin that is greater than 2 milligrams per deciliter, that you reduce the dose by 25 to 50%. It is excreted by the kidneys, and something to warn the owners about is that it may turn the urine an orange-red color just because the drug itself is red. This is the primary route of excretion in the cat, and we'll talk about that again when we start talking about toxicities. It's used for a wide variety of tumors. It's actually part of a number of different protocols and has been used commonly for liposarcoma, hemangiosarcoma, and osteosarcoma, either as a single agent or in combination with other chemotherapy drugs. The primary toxicity associated with doxorubicin include three separate toxicities. The first is anaphylaxis. And we pre-treat all of our patients that are receiving doxorubicin with Benadryl, and we make sure that we've calculated the dose for treatment of anaphylaxis for both Benadryl and some kind of a steroid, a rapidly acting steroid such as solu-delta-cortef or solumedrol. We do also see problems with toxicity if the chemotherapy agent gets out of the vein. It is a vesicant drug. It causes severe tissue damage, and so we give this drug through an IV catheter. If it gets outside of the vein, if you start to see evidence of swelling around the catheter site, the drug needs to be stopped immediately. You need to aspirate back as much drug as possible. Treatment of extravasation of doxorubicin from this point on is very subjective, and you'll see a number of different methods that various people will swear by. Mostly what we do is we tend to treat them by using hot and cold packs. We will sometimes infiltrate the site to try to dilute the drug out, but you also run the risk then of spreading the drug around, and so there's a little bit of a catch-22 there. So the best thing is to just make sure, as sure as you can, that you have excellent catheter placement and that you don't get the drug out of the vessel to begin with. It is also known to cause a dose-dependent cardiotoxicity. You can actually see cardiotoxicity. You'll see a range of cumulative doses anywhere from 180 to 240 milligrams per meter squared. We tend to be relatively cautious at the University of Florida with our use of doxorubicin, so we usually don't go over 180 milligrams per meter squared. This toxicity, although it is most commonly seen associated with multiple doses of doxorubicin, has actually been reported as an acute toxicity following a single or sometimes the second dose. So owners should be warned about it. There are a number of different things that people will do to try to make sure to check before they give the drug to make sure that they're not at risk. Anything from evaluating ECGs to doing chest films to doing echocardiography. At least at this point, none of those things have been shown to be a sensitive indicator of impending cardiotoxicity. There is a human drug called dexrazoxone, which has been used to protect the myocardium in people. There's been some reported use in dogs, although there's no reports yet as to whether it's been effective. Dexrazoxone is a free radical scavenger, and so it prevents the oxygen-free radical damage that is associated with cardiotoxicity. Doxorubicin's trade name is called adriamycin. Actinomycin D actually undergoes minimal metabolism within the body and is excreted largely unchanged in the urine and in the feces. The primary toxicity is bone marrow suppression, although gastrointestinal toxicity has also been seen. It does not cross the blood-brain barrier, so it is not effective at treating central nervous system tumors. It is most commonly used as part of a combination protocol for rescue of lymphoma patients or in patients where underlying cardiotoxicity or cardiac disease is thought to occur. It is often used in place of doxorubicin because it does not have the cardiotoxic side effects. It goes by a number of different names, including dactinomycin and cosmogen. The plant alkaloids are also cell cycle phase specific. They bind to the microtubules of the mitotic spindle and render it non-functional. So they act at the mitotic or M phase of the cell cycle. They're derived from the periwinkle plant and go by the common names of vincristine and vinblastine. The interesting thing about this particular class of drugs is that we typically don't see class cross resistance. That's not to say that it can't occur, but if an animal develops resistance to vincristine, it is not necessarily resistant to vinblastine. Vincristine is probably the most commonly used of the plant alkaloids. It is excreted through the biliary tract, and so again, it's important to reduce the dose when the bilirubin exceeds 2 milligrams per deciliter. Like doxorubicin, it is a vesicant, which means it will cause tissue damage and can cause sloughing if it is given outside of the vein. Some of these sloughs can be severe enough that they can require surgery. They can actually slough down through the tissue down to bone. We were very lucky with this particular dog. You can see the reddened area where there's loss of hair. Fortunately for us, that was as bad as that got, and that dog healed just fine. But it is something to consider, and many people will not give vincristine through any other method than through a catheter as well. And it's something to consider because, as we said before, it can cause severe tissue damage. It can cause myelosuppression. In most texts, it's listed as being mildly myelosuppressive. One of the other things to keep in mind, though, is that oftentimes in some protocols it is given in combination with L-asparaginase. And it seems that L-spar or L-asparaginase potentiates the myelotoxicity, and so we can actually see significant neutropenia when those drugs are given together. We'll talk about that a little bit when we talk about L-asparaginase in just a few minutes. Unique to vincristine is the potential for causing a peripheral neuropathy, and this can manifest itself as rear limb ataxia. Typically this occurs after several doses of vincristine have been given. In some animals it will resolve if you stop the vincristine. Obviously this is another side effect which, if seen, would mean that that animal would no longer receive this drug. We use vincristine primarily for the treatment of lymphoma in combination with a number of other drugs, and it is one of the treatments for transmissible venereal tumor, which is one of the only tumors that we can actually cure with chemotherapy. It has also been used in the treatment of immune-mediated thrombocytopenia because it does stimulate early release of platelets from the bone marrow. It's still controversial as to whether those platelets are functional, and so the use of vincristine for immune-mediated thrombocytopenia is still also controversial itself. Vinblastine is the other plant alkaloid that also undergoes biliary excretion, so similar to vincristine, it needs to have its dose reduced by 25% or so when the bilirubin exceeds 2 milligrams per deciliter. It is also a vesicant, and in that way is very similar to the vincristine, but we don't at this point have any reports of cases of the peripheral neuropathy. So if you have a patient that develops the peripheral neuropathy with the vincristine, you may substitute vinblastine. It's used most commonly by the University of Florida in the treatment of mast cell tumors in combination with prednisone. And as I mentioned before, it can be substituted for vincristine if a neuropathy is suspected. Moving into the hormones, we are talking primarily about prednisone, prednisolone, and dexamethasone. These drugs act by binding to cytoplasmic receptors and inhibiting DNA synthesis. They are also primarily lympholytic, which is why they're often used for the treatment of lymphosarcoma. Their toxicities, as far as chemotherapy drugs go, would be what we consider to be relatively mild, although the owner sometimes sees these effects more than we do, and so for some owners these side effects can be very significant. Polyuria and polydipsia and polyphagia are the most common side effects that we see associated with prednisone use, and the polyuria and polydipsia, especially early on in some of the lymphoma protocols, can be profound to the point where owners will threaten euthanasia of their patients because they just cannot handle the animal having to urinate 12 or 15 times a day. One of the least remembered side effects we tend to forget to tell owners about is that prednisone and prednisolone tend to make dogs and cats, dogs predominantly, not so much cats, make dogs pant. And that can be significant. Owners often interpret this as having difficulty breathing. So it's important to warn them, especially if they're going to be on high doses of corticosteroids, that panting is a very common side effect. At high doses, they can also cause GI ulceration. In animals that are sensitive to the steroids, it doesn't even have to be that high a dose. So owners should be warned to watch their patients or watch their animals for signs of GI ulceration, such as black tarry stools suggesting melena, or for vomiting with coffee ground-like materials suggesting that they've got gastric ulcers. The primary use for most of the steroids is in the treatment of lymphoma and for mast cell tumors. We do also use it for palliative treatment or symptomatic relief of signs associated with insulinomas, but these tumors are actually very rare, and so it's not something that is commonly used. It's also used for intracranial neoplasia, more for its potential to reduce edema that's secondary to the tumor than for necessarily any direct anti-neoplastic effect, unless you're talking about central nervous system lymphoma. It's important not to use corticosteroids concurrently with non-steroidal anti-inflammatory drugs. Both of these drugs have the potential to cause GI side effects such as GI ulceration, and their use of them together will potentiate their action. And so it's important because many of our patients that are treated for cancer are older patients. Often they have some kind of arthritis and are often on aspirin or Rimadyl or analgesic, and we do not recommend concurrent use of prednisone with any of those drugs. Moving on to the miscellaneous drugs, the drug that falls most commonly into this class would be the drugs that we consider to be enzymes such as L-asparaginase, and then the platinum compounds such as cisplatin and carboplatin. L-asparaginase acts by degrading asparagine, which tends not to affect normal cells because normal cells can synthesize their own asparagine. Tumor cells, however, cannot, and without asparagine, they die. The platinum compounds are cell cycle phase nonspecific, and they bind to DNA and prevent protein synthesis. We actually don't know how L-asparaginase is metabolized. As far as the toxicities go, the most common one that we see associated with L-asparaginase is anaphylaxis. This is a foreign protein, and so the more times you give it, the more likely you are to see the development of an anaphylactic reaction. However, it is possible to see an anaphylactic reaction to L-asparaginase following the first dose. So after this drug is given, it's recommended that you monitor the animal for 20 to 30 minutes. That's not going to guarantee that an anaphylactic reaction is not going to occur, but the majority of them occur within this time frame. And if they occur, obviously you can no longer give L-asparaginase, and you would treat that like you would treat any other anaphylactic reaction, usually with Benadryl and rapidly acting corticosteroids, plus or minus epinephrine, depending on the severity of the reaction. As we mentioned before, it is thought to potentiate vincristine-induced myelosuppression. The thoughts are that it may affect hepatic metabolism, it may slow the metabolism of the vincristine by the liver, and so it may prolong the circulating levels of vincristine such that we see a higher toxicity effect. It has been reported to cause pancreatitis. This is very uncommon, but I would not recommend giving it to an animal that you know has had pancreatitis in the past. However, as I mentioned, it is a relatively uncommon side effect. It is not myelosuppressive. It's one of the few chemotherapy drugs other than the glucocorticoid that do not cause bone marrow suppression. Because of this, we will sometimes use it in animals that have low white blood cell counts, that we're too concerned to give them a normal chemotherapy agent that might drop their white count even further. So we will use L-asparaginase in that case to at least give them some chemotherapy, even though we can't give them the drug that we'd like to. It's used most commonly for treatment of lymphoma. The unfortunate thing is it's a very good drug for treatment of lymphoma. Most lymphomas respond very, very well and very rapidly to L-asparaginase. The problem is that they rapidly develop resistance. They develop resistance by essentially mutating to the point where they can produce their own asparagine, so they no longer need asparaginase to be present in circulation. Cisplatin is one of the platinum drugs. It's renally excreted and is nephrotoxic. And because of this nephrotoxicity, a relatively extensive diuresis protocol needs to be used whenever this drug is used. You need to have an animal on a high rate of fluids and be diuresed for 4 hours preceding the drug and 2 hours following the drug. And this is sometimes very labor intensive, and so we've tended to move away from cisplatin as carboplatin has become more prevalent. It can cause pretty significant GI side effects, and so we prophylactically treat our patients with antiemetics such as metoclopramide. Some people will use butorphanol. Ondansetron is another human drug that can be used, although it is very expensive. Cisplatin cannot be used in cats. So like fluorouracil, it is one of those drugs that is absolutely contraindicated in cats because it causes a fatal pulmonary edema. We use cisplatin primarily for the treatment of osteosarcoma, either on its own or in combination with abramycin. It's also been used to treat various squamous cell carcinomas with some success. It also goes by the trade name of platinol. Carboplatin also undergoes renal excretion, but does not have the nephrotoxicity that cisplatin does. Its primary toxicities include bone marrow suppression, which can be quite significant, as well as specifically causing decreases in platelets. So this is another drug where you need to monitor the platelet count very closely when you are treating these patients. The other nice thing about carboplatin is it's safe for cats. So in cats that have soft tissue sarcomas, such as fibrosarcomas, or cats that have osteosarcoma, we can use this drug safely in these animals. It does cause GI side effects, although it's reported to cause fewer GI side effects than cisplatin. We still pre-treat our animals with something like metoclopramide, and we usually send them home with 2 or 3 days worth of metoclopramide just to try to avoid the GI signs that we associate with it. Okay, we've covered the majority of the commonly used drugs, and so what I'm going to do is quickly run through some of these tumors. And obviously we could spend days just talking about each tumor individually, so this will be a very, very quick overview. Lymphoma is by far the most common neoplasia that we see in dogs and cats, and it takes care of 90% of all of the hematopoietic tumors that we see in both species. Of the cancers that we see, it is the most responsive to chemotherapy, but there are some species differences as far as its presentation and as far as our expectations. We usually make a diagnosis by aspiration of a lymph node or by biopsy of either the lymph node or whichever other body site we think is involved. And when we start talking about species differences, we'll talk about some of the differences between dogs and cats and why lymph node aspirates are not always terribly helpful in diagnosing lymphoma in cats. In dogs, peripheral lymphadenopathy is the most common clinical presentation of lymphoma, and it's generally referred to as multicentric lymphoma. It can actually affect all breeds of dogs. It is reported to occur with a higher prevalence in certain breeds and certainly in purebred dogs. And these dogs tend to be middle-aged, although occasionally we will see lymphoma in dogs as young as 16 or 18 months of age. There are a number of factors that are considered to be prognostic when you're trying to discuss life expectations with the owners. Animals that present that are hypercalcemic tend to have a worse prognosis. Those tend to be T-cell lymphomas, which we know are less chemotherapy responsive. Animals that have received that have received corticosteroids prior to the diagnosis of lymphoma and prior to the institution of chemotherapy also have a shorter lifespan or shorter predicted lifespan, because use of the corticosteroids activates the multi-drug resistance gene, which allows the tumor to become resistant to a number of the chemotherapy drugs. Stage is also one of the prognostic factors. Animals that are considered to be stage 4 or 5, that is, they have multiple organ involvement or they have bone marrow involvement, have a worse prognosis than animals that are in stages 1, 2, or 3. The clinical presentation for cats is somewhat different. They tend to have either GI lymphoma or mediastinal lymphoma. Multicentric lymphoma is actually relatively rare, although there have been reported pockets of multicentric lymphoma in cats in various locations in the UK and in the United States. Animals that have GI lymphoma tend to present with vomiting, diarrhea, and weight loss, as might be expected. And animals that have mediastinal lymphoma often have pleural effusion, and they present with dyspnea. Cats that have GI lymphoma tend to be older cats, and they tend to be feline leukemia negative. Cats that have mediastinal lymphoma tend to be younger cats and are most commonly, probably in 70 to 80% of the cases, they are feline leukemia positive. As with the dogs, stage is a prognostic factor. Feline leukemia status is also a prognostic factor, not so much in whether or not the animals will achieve a clinical remission, but in their median survival expectancy. So cats that are feline leukemia positive tend to respond to chemotherapy initially, but their median survival time and their remission time is shorter than animals that are leukemia negative. Osteosarcoma most commonly presents as lameness. The most common sites, most people will remember them as being close to the knee or away from the elbow. That is, close to the knee in the distal femur and the proximal tibia, or away from the elbow in the proximal humerus or in the distal radius. Typically, this shows up on radiographs as a mixed lytic and proliferative lesion, and oftentimes these animals will be acutely lame. They may respond to some kind of anti-inflammatory drug, whether it's a corticosteroid or to a nonsteroidal such as Rimadyl, but when the Rimadyl or the corticosteroid is taken away, they become lame again. And so we know that we tend to see it in large and giant breeds. We also know that it has a bimodal age peak, with one peak occurring somewhere around the 18 to 24 month range and another peak occurring at 6 to 8 years of age. The obvious difficulty is in that first peak in the 18 to 24 months in the large and giant breeds, you may also be dealing with panosteitis, and really the only way you're going to know or to have an idea of whether you might be dealing with osteosarcoma is going to be to radiograph the leg. So the breed and the age should give you some index of suspicion, and then you would turn to radiographs to try to either rule it in or rule it out. And more likely you will try to rule it out if you have no lesions at all. It is a highly aggressive tumor. It is highly metastatic. We know that 90% or better of these patients will have metastasis at the time of diagnosis. The problem is that not that many will have actual radiographic evidence of metastasis at the time of diagnosis. We know that they most commonly metastasize to the lungs, and that most of these animals will die from their metastatic disease, whether they are treated or not. The final diagnosis has to be made by bone biopsy. If you take radiographs and you see a lytic lesion, the primary differentials would be osteomyelitis versus osteosarcoma. And so a bone biopsy is necessary to determine whether or not this is truly osteosarcoma. And for the pathologist to make a diagnosis of osteosarcoma, they must find osteoid in the histopathologic sample. Treatment recommendations for osteosarcoma, primarily we talk about amputation. Some people will consider limb spare procedures if the tumor is located, for example, in the distal radius. The proximal humerus is not really a great site for a limb spare, so most of the time with those patients, you're generally thinking about amputation. Amputation or limb spare alone results in a median survival of 162 days. If you add chemotherapy, depending on which chemotherapy protocol you add and which research protocol you look at, the median survival time increases to somewhere around 300 to 400 days. Some people, if surgery is not an option and they don't wish to pursue chemotherapy, radiation can be used to palliate the pain, but generally is not expected to actually prolong survival. It just makes the animals' pain go away. It makes their quality of life better. Some people can't afford chemotherapy. Chemotherapy, remember, these are large and giant breed dogs. The chemotherapy agents that we use can be quite expensive, but amputation can actually provide very good quality of life for a period of time. It may not be as long as if they treated them with chemotherapy, but their quality of life, once you remove the pain of the tumor, is actually quite good. Hemangiosarcoma can present with a number of different clinical signs. It may present with abdominal distension if you have a very large splenic mass. It may present with hemoperitoneum. They may present just collapsed and in shock, either because they've had an acute bleed into their abdomen or because they have hemangiosarcoma affecting the heart and they now have pericardial fluid that is causing cardiac tamponade and poor cardiac output. So these animals can present in essentially an emergency state. We see it most commonly in large breed dogs. German Shepherds and Golden Retrievers seem to have a higher prevalence or a higher incidence than many other breeds, and it does tend to be a tumor that we see in older animals. The average age is around 10 years of age. One thing to keep in mind with these dogs is that some kind of a coagulopathy is very common, and that'll be important when we start talking about how we go about treating these animals. The most common location for hemangiosarcoma is on the spleen. The second most common would be the right atrial or right auricular appendage. These account for about 75% of all the hemangiosarcomas that are reported. It can also be seen in the liver, it can be seen on the skin, can be seen in vertebrae, can be seen in the kidneys. But the spleen and the right atrium are the most common sites. The diagnosis, usually we have a pretty high index of suspicion based on a history. They oftentimes will have a very typical history of being very, very weak for several days, very suddenly, and maybe having pale gums if the owner happens to be astute and happens to look at their tongue or at their gums. And then they sometimes will get better without any apparent treatment. So the owner will say, yeah, you know, they were really, they were down, they wouldn't get up, they were very weak, they were very pale. And then, you know, over a couple of days, they just got better. And this is pretty common with dogs with splenic hemangiosarcoma because they will have a rupture of the tumor, they will bleed into their abdomen and become very hypovolemic and hypotensive. But as they autotransfuse and reabsorb those red blood cells, their red counts will come back up and they'll actually perk up without any treatment at all. So that's something that I listen for when I have an owner that talks to me about animals that have acute collapse. Additionally, on physical exam, if you hear a muffled heart, if you palpate an abdominal mass, if the heart rate is very rapid, if they have very pale mucous membranes, those are all things that are going to make you think this may be a case of hemangiosarcoma, especially if it happens to be a German Shepherd or a Golden Retriever. You also evaluate radiographs. Radiographs can tell you whether there's fluid in the abdomen. If there's not fluid in the abdomen, it may highlight an abdominal mass that is sitting in the region of the spleen or the liver. Or you may take a chest radiograph and find that you have a huge globoid heart or cardiac silhouette, and it's really not the heart you're seeing, it's the animal with pericardial effusion that makes the heart look like a giant pumpkin. Ultrasound is commonly used in these patients. One thing to keep in mind, if you ultrasound the abdomen and you see a mass on the spleen that looks cavitated, this is not diagnostic for hemangiosarcoma. Splenic hematomas and hemangiomas can look identical, so it's impossible to give a true diagnosis of hemangiosarcoma strictly from an ultrasound. Now, if you have a breed predilection, if you have a German Shepherd, if you have all the clinical signs, then the likelihood is that it is a hemangiosarcoma, but it is not absolutely diagnostic to simply do an ultrasound. Some people will do fine needle aspirates of the spleen. There are those that feel that it's contraindicated because you may seed the abdomen with tumor cells. So the ideal way to get a diagnosis of hemangiosarcoma, particularly of the spleen, is to do a surgical exploratory, to remove the spleen and have histopathology done. But keep in mind, many of these animals will, as I said, have coagulopathies, and so it's a good idea to try to assess clotting status at some point, either by running a PT-PTT or an activated clotting time. Probably a mucosal bleeding time is not a bad idea because they can also have some platelet abnormalities as well. Many of these animals will present and be either in fulminant or low-grade DIC, and so they will require blood products to make them even stable enough for surgery. So these are difficult cases to treat, and sometimes owners will elect not to treat them based on the fact that hemangiosarcoma has a poor long-term prognosis. Surgery alone in the treatment of hemangiosarcoma carries a median survival time of about 83 days. Surgery plus chemotherapy does prolong the median survival time to 179 days. Most of these chemo protocols are doxorubicin based, but again, you're talking about somewhere between 4 and 6 months, and so for some owners that's not feasible, and so they should know going into whatever treatment protocol they elect, whether it's surgery alone or surgery plus chemotherapy, that the long-term prognosis for their pet is actually pretty poor. Mast cell tumors are very common tumors. We see them in dogs, and they can look raised or ulcerated on the skin. They can actually look like pretty much anything. They can look and feel like lipomas. They can look and feel like cysts. And so it's very important, especially when we have breeds that we know are predisposed, such as Bostons and Boxers, we need to do cytology on these masses. They can occur at any age, and in some Boxers, you'll actually see them occur at very young ages. The diagnosis of a mast cell tumor is generally made on cytology, so a fine needle aspirate of a cutaneous mass or a subcutaneous mass will show a large number of cells that have these metachromatic granules, and this is pretty much pathognomonic for a mast cell tumor. In order to grade the tumor, however, you need to have histopathology. And histopathology is important because grade does have some prognostic implications as far as whether chemotherapy should be used, whether adjunctive therapy such as radiation should be used, or whether any additional therapy is indicated at all. Some of the prognostic factors for mast cell tumors include location. Animals that have mast cell tumors on the trunk tend to have a poorer prognosis than animals that have mast cell tumors on the limbs. Well-differentiated tumors carry a better prognosis than poorly differentiated tumors, and with very well-differentiated tumors, oftentimes surgical removal is the only treatment that's necessary. With grade 2 or grade 3 tumors, typically we are talking about surgical excision followed by some adjunctive therapy, but it's always hard to tell. What we typically recommend is that you have wide surgical excision, and this is where doing the cytology beforehand comes into play. So if you know before you take an animal to surgery that the tumor is a mast cell tumor, then you can plan to have a wide excision. You won't know what the grade is until you get your histopathology back, but if you have a wide excision and it comes back as a grade 1 or a grade 2 and you have complete excision, you may consider no further therapy in those animals and just monitoring them for recurrence. A grade 3 tumor tends to be more aggressive. They tend to have local recurrence and sometimes can spread to other sites. And in those cases, radiation treatment is definitely recommended, plus or minus chemotherapy. Mast cells are very radiation sensitive, So if you have a grade 2 tumor that you have incomplete resection and the owner does not want to consider surgery, or if it's in a site that's not amenable to additional surgery, radiation would be the treatment of choice. In cats, mast cell tumors typically present as hairless masses. They're not all that common in cats. We don't really have a lot of information about their biologic behavior, and we have not identified any specific prognostic factors for mast cell tumors in cats. At this point, we make similar recommendations to dogs, but that's largely because we have very little information on the natural behavior of mast cell tumors in cats. And so again, we usually recommend wide surgical excision, plus or minus radiation, depending on whether that excision is complete. Squamous cell carcinomas, especially oral squames, are the most common oral tumors in cats, and are the second most common oral tumors in dogs. Most common signs that we see associated with these tumors are associated with the fact that these tumors are often ulcerated and painful, so the animal will have a lot of drooling, they'll have halitosis because they'll get infected, and they may have a decrease in appetite, or the owner may notice that they seem to want to eat, but they'll go over and they'll pick up their food and then they'll just drop it because it seems uncomfortable to them. The diagnosis is made on histopathology. It's a pretty aggressive tumor. Local recurrence is very common at all sites, and tumors that involve the caudal tongue or the tonsils tend to spread to the regional lymph nodes and then often spread to the lungs. So these can be very difficult tumors. We like to catch them early on and treat them aggressively because, as we said, the smaller they are, the more likely we are to be able to remove them surgically to try to reduce the local recurrence rate. With surgery in dogs, the median survival time for oral squames is between 9 and 18 months. It's a bit shorter in cats, and surgery is not tolerated as well by cats as dogs. Cats tend not to like surgery on the oral cavity or on the nose. They tend to quit eating, and so if you have an oral squame in a cat that you're going to attempt to resect, I'd recommend placement of a gastrostomy tube or an esophagostomy tube so that the cat can be fed during the immediate post-op period while its mouth is healing. They are somewhat radio-responsive, and so radiation is sometimes used as a palliative treatment or in combination with surgery to try to clean up dirty margins. Oral melanoma is the most common oral tumor in dogs, very uncommon in cats. Again, the similar clinical signs that are seen with the squamous cell carcinomas, because again, these tumors are often ulcerated, so they have bleeding from the mouth, they will have salivation, they'll have halitosis. 33% of the patients will have what we call amelanotic melanomas, that is, the tumors will not be pigmented. One of the signs that we look for, though, is ulceration. That won't differentiate it between a squamous cell carcinoma and a melanoma, but may make you think that it's less likely to be something like an epulis. Unfortunately, melanomas are also highly aggressive tumors. They have a very high metastatic rate. Most of them will metastasize to the regional lymph nodes, followed by the lungs. And even when we attempt surgical resection, they often have local recurrence as well. And so these are very difficult tumors to deal with. Generally, we can make a diagnosis on cytology if we find the typical round cells with these very black granules. But poorly differentiated melanomas are difficult to diagnose, even with histopathology. Sometimes it requires special staining. They can actually look like a number of different other tumors, and so it requires a good pathologist. Prognostic factors for melanomas include location. Tumors that are located on the rostral mandible tend to be more successfully treated, partly because we can usually get wider resections, and so we cut down on the local recurrence rate. Size is also a prognostic factor. Tumors that are less than 2 centimeters in size do better than tumors that are larger. And then stage. If animals already have evidence of metastasis to the regional lymph node, in this case one of the submandibular lymph nodes, their prognosis is much worse. So typically, because these do tend to metastasize and because they do recur locally, most of the therapy that we use is considered to be palliative, including surgery, although occasionally we will get long-term survivors. In the past, we've considered these tumors to be non-radiation responsive. However, recent studies have shown that they may respond to some degree to radiation. However, it's typically used in conjunction with surgery to, again, try to clean up dirty margins. So it's used following surgery in cases where tumors have extended to the margins of the excision. There have been reports of using chemotherapy to treat this type of tumor. However, in general, they are not successful, and so chemotherapy is not strongly recommended for the treatment of oral melanomas. Squamous cell carcinoma in the cat tends to show up associated with sunlight, and so we see it most commonly in white cats on lightly pigmented areas, such as on the tips of the ears or on the nose. In dogs, it shows up more commonly on the feet or on the toes, and generally occurs as an ulcerated lesion. As mentioned before, we think that this is related to sun exposure. It's certainly relatively common in sunny states such as Florida and in high-altitude states such as Colorado. The primary treatment for squamous cell carcinoma is surgical removal, plus or minus radiation, again depending on whether surgical margins are clean. It does have a tendency to recur locally, however, so wide excision is recommended. Multiple myeloma can actually have a number of different clinical presentations. Animals may present for weakness associated with anemia due to myelophysis or invasion of the bone marrow and fibrosis of the bone marrow due to invasion by the tumor. It can also present as a lameness or generalized pain that is associated with bone lysis and bone pain. Some animals will present with a history of polyuria and polydipsia that is a result of hypercalcemia or sometimes as a result of proteinuria. It's more commonly seen in purebred dogs and tends to be in older animals as well. Multiple myeloma is very uncommon in cats, although it can occur. On a complete blood count, you may see anemia, as mentioned before, as well as neutropenia, depending on the degree of bone marrow invasion. And a hyperglobulinemia on a clinical chemistry should definitely raise your index of suspicion and potentially prompt a search for this tumor, especially if it's in a dog. Radiographically, you may see multiple lytic bone lesions, and this is one case where it's very important when you are doing your films to make sure you read the entire radiograph. Oftentimes this can be picked up when somebody takes chest films and notices that there are multiple punched out lesions in the dorsal spinous processes of the vertebrae. Sodium electrophoresis, serum electrophoresis will often show a monoclonal gammopathy, and this is almost pathognomonic for multiple myeloma. There are a few other diseases, both infectious and cancerous, such as lymphoma, fungal infections, or ehrlichia, that can also cause a monoclonal gammopathy. But if you have a monoclonal gammopathy in conjunction with these lytic bone lesions, in conjunction with some of the other clinical signs, this, again, should raise your index of suspicion. On your analysis, you may find a proteinuria, and you may or may not be able to find Bence-Jones proteins. The diagnosis of multiple myeloma is typically made from a bone marrow aspirate. And there are a number of criteria that have been set forth by various pathologists, but typically what we will use is the presence of plasma cells as greater than 30% of the nucleated cell population. We've also found that the presence of hypercalcemia or the presence of Bence-Jones proteinuria are negative prognostic factors with this particular tumor. The treatment of multiple myeloma is typically chemotherapeutic, so we typically use melphalan and prednisone. And actually, many animals will have a relatively good survival time for, if you consider what the median survival times are for most of our cancers. The median survival time in patients without hypercalcemia is almost 2 years, and with hypercalcemia still is approaching 9 or 10 months. And so considering that median survival times for things like osteosarcoma and hemangiosarcoma are typically in months, that's actually a pretty good response. One of the things to consider when you have a treatment failure is why do these treatments fail? Why are we not effective at curing cancer with chemotherapy? And there are a number of different potential factors. One is that we can't use extremely high doses of these drugs because then we will end up with intolerable side effects. We also know that over time, the cancer cells will develop resistance to these chemotherapeutic agents, either because they will change transport mechanisms, they'll develop alternate metabolic pathways, and because of potentiation of the multi-drug resistance gene. Some tumors may have intrinsic resistance. Large tumors, which tend to have fewer cells and actively dividing, tend to be more resistant. Additionally, these tumors, because they are large, they also have cells that undergo spontaneous mutation. And we know that the rate of spontaneous mutation in many tumors is higher than the rate of spontaneous mutation in the average tissue. And so it's very likely that any given tumor will have some cells that are resistant. And the larger the tumor, the more likely they are to have more cells that are resistant. The tumor may occur at a protected site. We know that many of the chemotherapy agents don't cross the blood-brain barrier, which means that central nervous system tumors, or tumors that occur, for example, in the eye, these are sites that are not readily accessible to many chemotherapy agents. Some tumor cells may be in a dormant state. We may have insufficient drug delivery. Many of these tumors have abnormal blood vessels, and so they don't have normal blood flow, which means that the drugs, which are typically given intravenously or intramuscularly, can't get to the tumor to have their effect. We also have to keep in mind that chemotherapy drugs are not truly directed just at cancer cells. They're directed at any cell that can be affected, typically the rapidly dividing cells. And what we rely on is that hopefully most of the normal cells will be able to repair the damage that we cause faster than the tumor cells. And so we specifically set up treatment intervals, whether it's for chemotherapy or for radiation therapy, to try to allow normal cells a chance to repair themselves while treating them soon enough to not allow that repair to occur with the cancer cells. So in conclusion, I realize this has been a kind of a whirlwind tour through the world of oncology, but it's something that is important in our patients today. Clients are demanding more treatment for their patients, and is something that hopefully will allow us to give our patients a longer quality of life. Thank you very much.